COVID-19 is prompting hospitals and healthcare systems to reconsider how and where they deliver care to patients. Many see the patient's home as the safest and most effective option for certain conditions and particular patients. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, Senior Writer with AHA. In this Members in Action podcast, Julia Resnick, Senior Program Manager at the AHA, is speaking with Dr. Nancy Guinn, Medical Director of Presbyterian at Home, and Dr. Elizabeth Pirro, Medical Director of Hospital at Home and Complete Care. They'll discuss how Presbyterian is improving outcomes and the patient experience while reducing cost through their hospital at home approach. Julia?
Hi. Today's podcast is part of the Members in Action series from the Value Initiative. We are highlighting how hospitals are improving value and affordability for their patients and communities. The hospitals we profile have all implemented strategies that improve outcomes, enhance the patient experience, and lower cost. Today, I'm pleased to be speaking with two physician leaders from Presbyterian Healthcare Services in New Mexico, Dr. Nancy Guinn, Medical Director of Presbyterian Healthcare at Home, and Dr. Elizabeth Pirro, Medical Director of Hospital at Home and Complete Care. We will be discussing Presbyterian's hospital at home efforts to improve value for their patients and community. Nancy and Isa, thank you so much for joining me today. Let's jump right in. So for those who are not familiar, I think it would be helpful to start with some background on the hospital at home and complete care models. Can you talk a bit about what hospital at home is and how it works?
So basically, Hospital at Home is a program that allows you to provide hospital-level care in the home. So for appropriately selected patients, they can have proper care, such as IV antibiotics or things of that nature, but in the home setting without having to go to the hospital, be separated from their families. So it is a very well-received program from that perspective. We started the program originally as an alternative to hospitalization, but as you're probably aware, there is many different uses of hospital at home in many different ways, depending on the estate's particular care needs.
I think the image of hospital at home is really valuable. It's hard to describe how different it is from a hospital. So we've all been in hospital rounds, where there's sort of this huge team that congregates around a whiteboard and a physician is standing there in a white coat surrounded by the nurses who are reporting on the patients. There's a social worker, there's a care manager, there is usually therapy team, perhaps the palliative team is there, whoever it is. It's a big group of people. And instead, if you have this image of Dr. Pirro driving around in a mid-sized SUV with the entire back of the SUV full of paper bags that are necessary to manage her PPE, which she's using going in and out of homes for possibly COVID-positive patients. And really operating, she has a trunk in her specific medications, which can be used for first use in emergency situations. She's got one or two cell phones going at all times, a laptop computer, and is met in the home by nurses who also are carrying supplies and also pharmacies delivering DME and supplies to us. So it's sort of this image of this single individual and a nurse accomplishing, most of the tasks that occur in a hospital setting. So it's a fascinating model to observe because it is so different, and it takes a person who has, I'd say, nerves of steel to be comfortable operating in that environment.
Yeah, I think what I would add to that is that now in the times of COVID, as we all know, a big difference has been that families are particularly sensitive to the fact that at least initially they couldn't see their family members if they were hospitalized. For the first 4 or 5 months, there was no contact, and that was terrifying to people. So I think that's another fact about hospital at home that has become much more pertinent in this time as families realize how important that piece is, that they have somebody there all the time and they can directly see progress and have direct access to the medical team to get questions answered. Nobody has to go search for anybody. We're in their base of power. So it is a very different dynamic, very patient-centered.
Yeah, that is wonderful to hear, especially considering what we're going through now with COVID. And so hospital at home is a national model, but I know at Presbyterian you've been doing this for many years, and I want to focus in a bit on how it works in your health system and in your community. So can you tell us about Presbyterian Hospital at Home and what inspired you to launch it?
So actually it was back in 2007, 2008 that we started working directly with Dr. Bruce Leff at Johns Hopkins, who was the person who developed this program, and actually worked with him quite a bit in developing our models, our diagnosis, our criteria, inclusion-exclusion criteria, a number of our care processes. We started the program for a number of reasons. I think part of it was just seeing how patient-centered the model was and being intrigued enough to jump in and try it. Presbyterian is pretty comfortable with innovation and willing to try things. The focus was twofold, maybe even threefold. We already had a home health agency, so there was a critical awareness of caring for patients in the home and the need for sometimes having far higher level of care than you're able to achieve through a home health admission. There was the sense of wanting to have a program that was effective for patients. Presbyterian is an integrated system. We have a health plan as well as our hospital and delivery system and a large medical group. So we were looking for a model that would offer the cost savings benefits that hospital at home probably would. That was critical. And then another feature in New Mexico, and it's really, I think, come to national awareness during COVID, is there are regions of the country that are more limited in their capacity, their bed capacity, than others. COVID has sharpened our focus on that because of the need to hospitalize patients who have significant cases of COVID. And New Mexico, across the country, probably has one of the lowest bed capacities per capita of any region. So our hospitals tend to run pretty darn full most of the time. So we were aware that any program we could develop that would correctly treat patients in the home and add to our hospital bed capacity would be highly valuable. So that was the motivation behind developing the program.
And you mentioned a bit about eligibility criteria. So who are the main patients or like the patient population that is best suited for the program?
Yeah, so first of all, it was for Presbyterian insurance patients, and that was because Presbyterian as an integrated health system was supporting the program, and of course Medicare did not participate in hospital at home programs, so Presbyterian insurance was one of the requirements. There was extensive inclusion and exclusion criteria, as Nancy mentioned, which was data that we obtained from Johns Hopkins University that they developed in their original program. So usually it had to be somebody that was sick enough to be hospitalized. They had to meet hospitalization criteria, but stable enough to be managed at home and had to consent to the program. It was completely voluntary. Over the years since our inception, most people have been happy to consent to being treated at home rather than going into the hospital. But at the base of it, I think the simple answer to that question is they had to meet hospitalization criteria, so be sick enough for that, but stable enough to be managed safely in the home environment. And another criteria was obviously that if they were alone, they had to be able to get up, to go to the bathroom, to get a glass of water, open and close the fridge if there's no family member to do it for them. So that was sort of our non-written criteria. You know, you'd go to the ER and one of the first things you would do was ask the patient to take a little walk to the door as a pass-fail if they were alone.
Mm-hmm.
I think the concept of being sick enough to be in the hospital is often difficult for clinicians who are referring to the program, because we all, as we're taking care of someone who's urgently ill, want as many eyes on them as possible. So we will get calls sometimes from referring physicians who basically say, the patient's kind of sick, would you admit them to hospital at home? And the question we ask is, would you admit them to the hospital? And they're like, no, they're not that sick. So we often get calls from referring providers who want to know if we can put eyes on a patient for them that they're sending home, for instance, from the emergency room. And we'll literally ask the question, are they sick enough to be in the hospital? And they're like, no, they're not that sick. At which point we would suggest other methods of following up, but not a full-blown hospital at home admission, which truly is a hospital admission.
Mm-hmm. That makes a lot of sense. Do you have any stories or examples that would help this come alive for our listeners?
So I thought about that some, and at the end of it all, we have a lot of stories. I think the most common one, just to be very current, because we have 9 years of experiences with different patients and families, to be more current, what has been a recurrent theme over the past 4 to 5 months, I think that really brings it home is actually we have our complete care program now where most of our admissions come from before COVID. But since COVID, we actually have gotten several calls from the emergency room where the doctor says patient needs to be hospitalized, but patient and family say no, they're going home. Because they would not be able to, the family wasn't in the ER, patient was going to be alone in the hospital. So they called us. And of course, they were extremely happy to get treatment in the home, get the IV medications, get the nurse there, feel like they were getting the support they needed, but have their family member where they could see them and see what was happening. And that's really important, especially for the elderly population, because in the hospital, especially without having their family members present, sundowning is a common problem, and it really causes a lot of distress, not just for the patient, but for their family, where if they're getting treated in the home, there's a lot less of that. They're oriented, they're with people they know in a place they know, and the family doesn't have the distress of the separation, So I think that has been sort of the COVID example, is that people who actually were told by a physician in the ER that they needed to go in, the family said, no, we want to take them home. And pretty much no matter what, we want to take them home because people were so scared, the first few months. So I think that's been a little bit of a different application in this setting. And of course, these were non-COVID patients, but the fear was such initially that it was nice to be able to offer that,
I was just remembering the very first patient admitted to the program, and I'm going to call him Walter, and that was sort of close to his name. I don't remember exactly. And we were so excited to start the program. We have so many pictures of Walter sitting in his recliner in his home with his number one. I think we even gave him a little number one foam thing to hold. Well, the original inception of the program, which, by the way, Isa, the years are passing again. It's been 12 years now. Time is going by. Walter, if I remember right, had advanced COPD and had a COPD exacerbation, so chronic obstructive pulmonary disease, and an exacerbation of that. Normally would have been hospitalized for it, but we were able to treat him effectively at home with all the medications, increasing oxygen supply, a number of things. And he was just so delighted to be able to stay in his home. So I remember those pictures of him so clearly. There's another woman who was an early customer of hers who would not leave her dog to go to the hospital. And I can remember her very clearly, too. Pictures
about the dogs and the cats. Yeah.
Yeah. So there's often a picture of one of our patients with an animal nearby because that is critical. And if you're an elderly person living with limited caregiving support, your animals are so critical to you, and leaving them can actually put you in a panic because there's no way for them to be cared for effectively. So a number of people who won't be hospitalized because of their animals, and we care for them too.
As a dog lover and owner, I absolutely love those stories, and know that, for age-friendly care and for, people who have pets, there's so many reasons why it's better to be treated at home.
Yeah, to say nothing of the sequelae of a hospitalization that can be really severe for a frail person, elderly person. It's not just delirium and the higher fall risk. Not because hospitals don't do a beautiful job of mitigating falls. I mean, we work in a hospital system that really focuses on that, but just an unfamiliar environment. And then, of course, all of the other things that we work to avoid and are concerned about, such as, the potential for infections, things like that. Yeah, any sense of increased weakness, more time in bed, those are huge insults for someone who is aging and frail. And so avoiding them as much as possible is really valuable.
So I want to shift to something that I think Isa mentioned a few minutes ago, but I want to address head on. So across the country, a major barrier to widespread adoption of hospital at home has really been payment. How has Presbyterian addressed this issue?
So Presbyterian from the very beginning developed this program to be compensated for by our health plan. And all these years later, and we've discussed this with major health plans, of course, we've been supporting the efforts nationally to have Medicare reimbursed for the program. We still have a single payer for the program, Presbyterian Health Plan. So the first criteria to receiving these services is that you are a member of our health plan. And the health plan, we from the beginning, the program was conceived of as one that would be reimbursed with an episodic payment from the health plan. It's high value for the health plan because it costs less to them than hospitalization. And of course, it's high value because it's good care and the outcomes are good.
Mm-hmm. So on that note, we're always interested in the impact of certain programs on value, which we define as part of an equation that includes improved outcomes, enhanced patient experience, and cost. So can you both talk a bit to the impact that Presbyterian Hospital at Home has had on value?
Presbyterian is keenly aware of value and of the need to address all three of those. And as a health system has actually adopted a real focus on the triple aim for a long time. A lot of that is due to the environment we live in. We are in a state that is quite poor, has a low percentage of employer-based health plans and a high percentage of government payers. So it's allowed us to have a very strong focus on all of these issues. In the case of Hospital at Home, an article was originally published on Hospital at Home and Health Affairs many years ago now, probably 8, 9, 10 years ago, that discussed that the costs were lower than an equivalent hospitalization. Over the years, since we have learned more about the program and become more and more efficient, the costs are significantly lower. At this point, we calculate that the cost of a hospital at home admission is probably about 42% lower than an equivalent hospitalization. So really high value in that, for sure, for the system. And the other value that's implied and never been calculated is the lack of post-acute care. Frankly, is often more expensive than the actual hospitalization. Our patients are often transitioned to an episode of home health care so we can keep close eyes on them through our home health agency. But our patients do not end up in a facility with all of the sequelae of being in a facility. So that's huge high value also. In terms of outcomes, I've already mentioned a couple of things. One is not having the sequelae of hospitalization and post-acute care and being able to reside in the home. That's really critical.
Mm-hmm.
As a part of every hospitalization, we track critical core measures that are used nationwide by hospitals, such as things as tracking the fall rate, infection rate, development of pressure ulcers, development of infections, medication errors. For each hospitalization, we track all those. We also track things like appropriateness of hospitalization. For instance, for heart failure, have they had an echo? We track immunizations. Are there pneumonia vaccines and flu vaccines up to date? All as part of the hospitalization. And in all of those measures, and most significantly the falls, medication errors, and readmission rates, we have very good numbers that are, for falls, pretty much near zero. Medication errors are at zero. Our rehospitalization rates are much, much lower than compared to, brick and mortar hospitalizations. So for all those core measures, we have always done very, very well. And also we do extensive patient satisfaction surveys. And as you might imagine, people have few things to say that are not glowing about getting hospital care in the home. So I think definitely an improvement there and also a cost saving. So you have to ask, why not?
Absolutely. And I think as COVID progresses, there are a lot more hospitals asking that why not question, and they're trying to figure out how to do this. Speaking of COVID-19, I assume that you've had to alter your program a bit as a result of the pandemic. Can you talk a little bit about how your work has changed over the past few months?
I'll address the hospital at home part, and then Nancy can address our a monitoring program that was developed as a result of the pandemic. So for hospital at home itself, from the very early days, it was clear that COVID patients that needed hospitalization should not be managed in the home. They had a tendency to decline very rapidly if they were going to decline, and we could not provide that level of care. So what we did instead was we improved efficiency of how we did things so that we could increase the number of patients we could carry on hospital at home on a day-to-day basis with other diagnoses that we normally manage on hospital at home, with the idea being that if we can help offload the hospital, they could have more beds available for COVID-19 patients who needed hospitalization. So we made all those changes very rapidly and basically tripled our capacity for admissions.
The docs being willing and the nurse practitioners being willing to actually do whatever was necessary to care for the patient. So if a nursing shortage was actually limiting our census, then they said, that's fine, we can hang the antibiotics also. So everyone kind of pitched in. and allowed us to increase our capacity, which was really valuable. We also started working with some of the clinical services at Presbyterian to redefine what a hospital at home admission was to be of service with them. So originally we were discussing with, for instance, the cancer group, what could we do to help them with patients who were at home who normally would have come into the infusion center to be treated for symptoms or been hospitalized to be treated for some of the conditions they might have, and worked on expanding our capacity to be of more service, for instance, to those patients. So that was our initial response to COVID. And we can all remember how fast we were scrambling in those days. The other thing we decided to do was build a program specifically around COVID. And we worked with our health plan on defining that program together with our team, and determined that what we wanted to do across the state of New Mexico, because our services are available across the state, was to work on developing a remote monitoring program for COVID. And literally within weeks, we obtained the supplies, developed the model, found all of the staff that we needed by being flexible within our own internal teams, and built a program where anyone who met criteria and had a COVID positive test, they got outreach from us quite rapidly. And we actually set up a home monitoring program if they wanted to enroll in it by using a smartphone app associated with our medical record that automatically pinged them several times a day to check on them. We overnighted or delivered oximeters and thermometers in the homes so we could actually monitor them, and started tracking these people. And that was our response to COVID in the home, was the monitoring program, which is still going on. It's been interesting how it really isn't a monitoring program. It's a treatment program. We built it in early days thinking monitoring would be the focus, but it turns out that the people who are most interested in being part of the program probably are those that have concerns about COVID, are very symptomatic, and are at great risk from COVID. I think the younger folks who have COVID, who are asymptomatic, when we reach out to them, just basically say, no, we don't need this. So it turns out that while it's a relatively small population we've been dealing with, about 80% of them require medical intervention as part of our care. So the moment that we don't hear from them, that we don't get a reading, that we get a reading that's abnormal, our medical team reaches out to them, and we start working on managing their condition, their symptoms, and doing anything that they need. Most of those folks end up having oxygen delivered to the home, and they're receiving calls from our team 2 or 3 times a day to verify that they're okay. We've been able to alert several people whose oxygen level was low, who weren't yet symptomatic, which is sort of a hallmark of COVID, and send them directly to the hospital or the emergency room to have them arrive, sometimes with significant hypoxia and a need, and pneumonia, and a need for hospitalization. Others have been able to be managed enough and returned home, and we followed them. And then there are a lot of people who, because we were contacting them, we were able to get them oxygen, we were able to treat their other symptoms, have never had to leave their homes during their illness from COVID. So that's how we've responded to COVID in our community.
That's great and really important work. So you mentioned that hospital at home has been going on for about 12 years now, and I'm sure that you've learned a lot over the last 12 years. What are some lessons learned that you could share with our listeners who might be thinking about starting up a home hospital program?
It's critical to find your payer, as we've already identified. And unfortunately, that's the first thing you have to do, because it's not a program that is accepted or reimbursed effectively yet. I sure hope that changes, because I think it's of high value. So understanding your payer, understanding your relationship with them. The other critical part of hospital at home is all in the operational delivery systems. You've got to have really stunningly good nurses who are comfortable operating in a home environment and not standing, with no one near them at that moment when they're working with patients. But they also have to have, I'd have to say, it's the emergency gene. This is not a home health program where your first job is to do a very long OASIS assessment of your patient, where the response time expected is in the range of 24 to 48 hours. This is an emergent program when it happens. So our response times have to be rapid. So we often end up hiring nurses who are from the emergency department and are comfortable with that level of response and enjoy that sort of urgency of response. So the team has to be critical. As I've already mentioned, you have to find advanced practice clinicians and physicians who are comfortable driving around in a car with a bunch of equipment and operating with their main backup being a telephone, and a laptop. We're high tech in that we have advanced cellular capability and we have a ton of different devices to communicate with each other. And we work really hard on that, but it's not high tech other than that. It's you and your stethoscope and lab draws and portable x-ray and portable echocardiogram, portable Dopplers are your main tools. And so you have to find folks who are comfortable in that environment. To my mind, those are the critical features.
I think one thing I would add to that, Nancy, also is, and this is based on the fact that especially since COVID, we've had several calls from groups that are considering starting a program. And one thing that comes through from all of them was that they really had not thought through very well what population they were going to serve. And that's sort of a critical, right out there from the gate. You have to know who's going to pay for it and who are you going to be taking on, right? A lot of these folks that called us were thinking pediatrics as well as adults. That's a completely different thing if you're going to deal with children, right? It's like, I don't do children. So that's, anyway, another point I would add to that, knowing who you want to treat. And another, some of those folks actually were considering, what do you do with COVID? Can you do COVID? And the answer was no, not if they require hospitalization. You can do monitoring like Nancy talked about, but not hospitalized in the home. It's not reasonable.
Often, if you're not careful, you find a solution and then decide which problem it applies to. So we often counsel people who come to us, and we've been training on hospital at home as well as our other programs such as palliative care for many years now. So the folks that come to us, the first question is, what needs are you addressing? Let's identify that. Is it your bed capacity? Is it your patient satisfaction? Is it, why are you pursuing this? And then at that point, once they can define that, then it's worth discussing which programs are most effective for those needs.
Absolutely. So looking towards the future, what's next for Presbyterian in this space?
Healthcare at home has always been an expanding program. As we mentioned to you at the beginning, we actually evolved from hospital at home into a full-blown house calls program, and then over the years have developed an advanced illness management program called Complete Care that takes care of over 700 of our medically fragile, frail, usually elderly members and patients in the home. That program provides primary care, urgent care, as well as hospital at home, and a ton of case management and supportive services to these folks, full spectrum care in the home. So that's the way we've been evolving for years, as well as having a robust community-based palliative program. And I would say that our work continues to expand in that direction. Of course, what we haven't mentioned yet is that it was important for us to develop telehealth capacity for our patients in the home, as many clinical settings did. And so how can we evolve along telehealth, and how can we continue to support particularly our Presbyterian Medicare Advantage patients with programs? So we're exploring other models. We started a complete care clinic about 2 years ago, probably as usual, it's 3 years ago. We're not adding up these years very well, are we? So 2 to 3 years ago, we started a clinic program for folks who are a little bit mobile. And what we've been working on now is kind of merging the home and the clinic program to address the needs that have come up through COVID. So I'm afraid that's a vague answer, but I think what you're hearing is a continued expansion into what has always been a goal for me, which is creating a seamless network of care for people in the last years of their lives to ensure that they don't fall into gaps of care. And that's the continued focus.
Wonderful. Isa, any final words?
No, I think Nancy said it very nicely. The Complete Care program, I think, has tremendous satisfaction for those of us who work there. A lot of folks may think that working with people who are frail, advanced stage, multiple medical problems is not going to be very satisfactory. And I think it's probably the most rewarding job I've done. It's hard work. It's interesting work. Folks as a whole are so grateful to be able to get the care they need in the home that it's been very rewarding. So I'm happy to see our programs grow as that population grows steadily in this state.
Thank you so much, Nancy and Isa, for joining me today and sharing your really important work. Your efforts around hospital at home are an excellent example of how hospitals can improve value, and we look forward to hearing how your work continues to grow.
Thank you.
Thank you, Julia.
And for more podcasts and additional resources to help you promote value in your community, please visit the Value Initiative's website at www.aha.org/The Value Initiative. That's it for today. Thank you for joining us and hope that you tune in to future Members in Action conversations.